welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I'm happy to be joined by Dr. Charlene Collier, who is a fellow OBGYN who lives and practices in Mississippi. How are you doing today?
I'm great. How are you today, Mary? Thanks for having me on.
Thanks for being on and agreeing to tackle a little bit of a difficult subject in the world today. So, as our audience knows, being an OBGYN in the summer of 2022 is a little bit more challenging than it used to be. So I want to just, start just getting to know you a little bit better. And we're going to spend some time talking about, just as OBGYNs interested in reproductive health justice, how the current climate in the country might affect what we do and the patients that we serve. But before we get into that, tell us just a little bit about, your background, why medicine, why OBGYN, what got you interested in women's health, and then we'll kind of go from there.
Yeah, thank you so much. And definitely everything you said, very true. It feels like every summer brings us a life-shaking change over the last few years. So I'm originally from Englewood, New Jersey. I'm one of those people who always wanted to be a doctor. Can't say exactly why. That type changed frequently through childhood, but when I got to high school, where I grew up, which was the public school I went to in Englewood, New Jersey, predominantly Black and Latino, began noticing increasing numbers of teen pregnancy and very little being done about it. And looking in the communities around me, seeing that there were differerences. And I didn't know the words for it back then, that they were disparities, but just seeing these differences and knowing that there were medical consequences to these things, or they did not have medical origins. It was not like my community had something else, medical, biological, that was driving these changes. There were social issues that were going on. There were social drivers for these differences that were going to have lifelong implications for my peers, myself, others. So that was what really sparked my interest in saying to myself, I want to be a doctor that can do something about this. So I knew that. Prior to that, I loved surgery. I wanted to be a surgeon. I wanted to have that kind of very hands-on clinical experience. So OBGYN became very naturally a great field for me. And I chose that in high school, knowing I wanted to practice as a clinician that could have an impact beyond that one-on-one clinical experience with a patient, but looking at how do we solve kind of population level challenges that have their roots in these social differences or these social drivers. So didn't have, again, those words of calling it social determinants of health or health inequities, but that's certainly what sparked my interest. And then as I progressed into college, learned about the infant mortality disparities around race, and learning that Black babies die at higher rates than white babies really, bothered me deeply. And again, knew that difference wasn't a biological difference, was not driven by something wrong with Black mothers or babies, but knew that was a reflection of social inequities and injustices, and knew that to solve that as a physician, you could not just go get a toolkit of medical tools to fix that problem. You could not train yourself in any amount of surgery or procedures or medicines to fix a problem like inequities driven by race. So even at that age in college, knew I had to sort of pull together a set of resources and training that would allow me to be that kind of doctor. That's kind of what started my process. I went to Brown as an undergrad, did the program in liberal medical education. So that was 8 years. I got to major in sociology. I took classes very much outside of just medicine, tried to study abroad, studied racism, because I knew that was very fundamental to understanding these inequities. When I got to med school, did my master's in public health at Harvard with a focus on maternal and child health, and then residency at Yale. After residency, I didn't choose a traditional fellowship. Many of my classmates did. I did the Robert Wood Johnson Clinical Scholars Program, which there were several sites around the country. Yale was one of them, and that prepares you in health services research, policy, leadership in healthcare, and really shows you the beyond even epidemiology or health disparities, which I had been studying, looking at health systems, understanding how politics plays into healthcare, and really built my skills and understanding around that. So that was kind of my background. And then just kind of possibly by serendipity, my roommate from med school was from Mississippi, and I flew down to be in her wedding and randomly met my husband to be, which kind of brought me to Mississippi. Didn't expect that, but really was a perfect opportunity to combine all the skills that I had, where I got to be a practicing clinician that could take on maternal and infant mortality in a place where clearly it was the worst in many factors. So since then, I've been working in a joint position with our state and my university hospital, where I still see and take care of patients, but working now over the past 10 years to develop programs and do epidemiologic research to understand maternal infant mortality in our state. So trying to combine all those, all that training and history in a career that allows me to, again, still see patients, take care of them. I don't do as much surgery. I definitely have dedicated more of my time to public health, where my passion is, but it's been a great journey, and something it's like very meaningful to be a physician that can combine, those practices. And it's really necessary for the problem we're trying to solve, because definitely there's no pill, prescription, or surgery that can fix some of the issues we particularly deal with in maternal and infant health.
Definitely. So, it's always interesting when we talk, because we have so many things in common. And so when you were talking about being in high school, and I didn't decide to be an OBGYN until the end of medical school, and I fought it so very hard. But similar story in high school, and I had a classmate that I tell the story, a classmate that was a few lockers down, and she would just go missing for large periods of time. Because at the time, when you were pregnant in high school, you went to a different school. You had your baby, and they had like childcare and in theory extra support, and then you would come back and you would go back. And she went missing quite a few times during high school. But thinking a lot about what that means for your educational trajectory, what does that mean for your employment and long-term career trajectory, what does it mean for those kids, and not kind of a better or worse situation, but it was just what does it mean? And so you mentioned health disparities and social determinants of health. And so, to the same thing, like I didn't really know what the differences meant, but I knew there were clearly differences. And for, people who are listening, we talk about social determinants of health a lot on this podcast, but just reminding you that those are the things that are outside of what we consider your person, your biological health, like all the things that affect your health, like where you live, how you have access to food, what's your housing situation, what is your environmental situation, are you in contact with pollutants and that type of thing. So, and there's more than that, but just for an example. And so in thinking specifically about women who are still not, sad to say, not equal citizens in this country, and we face discrimination on multiple levels, and decisions like the current one, this overturning Roe v. Wade, has, particularly effects on people who identify as women and who have the ability to be pregnant. And so kind of giving a little bit of context for us, and thinking about what it's like to work in rural Mississippi. So we have population who already across the board is marginalized. That makes up half the country. Then we think about specifically Black and brown women who are in this country who are discriminated against on a larger level. And then we think about those who are on underinsured or Medicaid insured in this country who have challenges financially, we'll say. And then we think about people who live in states where there's the big states where there's a large rural population, and you just generally have less access to care. It just compounds the issue at every level. So talk to us a little bit, just more specifically about access to care in general, and then we'll get kind of into a little bit more specifics when we think about women's access to care, and then Black and brown women's access to care in this country.
Yeah. I've definitely seen the full spectrum, from working in Boston, where it felt like, community health centers had more resources than some, major universities in other states. And like, there was such a concentration of wisdom, knowledge, experience, just heavily concentrated. I mean, one department can have, 10 of the world's top researchers on a topic. You have some of the best hospitals in the world. You have numerous interconnected programs, and yet and still a place like Boston can have health inequities, disparities, and poor outcomes. Going from there to practicing in Mississippi, where I'm in Jackson, that's a capital. It is not uncommon for people to have to travel an hour or more for routine care. So many communities across the state where that is the baseline, an hour is actually not considered even too long for some people. So 2 or more hours, some people have to travel to get basic reproductive health care. I mean, even just pap smears or a mammogram. If they have just a complaint that they're concerned about, have to make an appointment and drive 2 hours. So prenatal care, you can imagine our cadence of visits where we're seeing people at some points weekly. That's every week, taking off pretty much a full day of work and those kind of implications. So that is not at all uncommon. We have what we call maternity deserts. We have about 80 hospitals in the state, and only half of them are obstetric. And of those, only a handful can provide full spectrum where you can get access to a specialist of some form. As it relates to reproductive care, contraceptives, and you may have access. So you're seeing an OBGYN or a nurse practitioner who has training in that, but then there's limitations even within that practice where you may have people who aren't trained to place an IUD, who hold fixed false beliefs about certain methods, and so deny that person. So as a person seeking healthcare, they walk into a practice thinking I've made it, and they really don't know if they actually have full access. They may not be fully educated. When they go into that practice, they may actually hear myths about it, even within that practice. So we still see a lot of that because in places, particularly where people are able to be the only provider, right? Like, so when we say access and you have that provider, the way that provider practices is what a person may get. So if that person is, in terms of the provider, doesn't support the use of full spectrum contraceptives or IUDs, doesn't support access to abortion, that means, that picture of access is actually even further, weakened because the hour away doctor that you just got to is actually not providing you comprehensive health care and not giving you choices around what you should know and have access to. So even as you just look at numbers and maps, it doesn't even capture that when you reach that, you're getting respectful, culturally concordant care where you're likely to encounter a person who is centering your needs. So even the map is probably a little less promising than it looks like. So because we're in a state where even education, so our state has abstinence only as its primary model, or it's abstinence plus, where you have to teach abstinence and then you can teach additional methods. But there are school systems, roughly half and half, where it's still abstinence only is the main education that they're getting. So you just have a population that is, not getting the education, not getting the resources. And then even a place like Jackson. So we all know as it relates to Roe, this all started with the one abortion provider in the state, which is painted bright pink in the middle of the city. But it's the only one. None of the providers that work there are really from Mississippi. They all have to come in, and none of the ones that come in have privileges at any of the hospitals nearby. And I work for the state, so we're really, by law, have never been permitted to do elective abortion. So there's been this, unspoken rule that everybody, if your patient needed one, they just go there. They don't even have to access their OBGYNs to think about this, because it was not the topic of conversation outside of that space. So all people who were seeking abortion services were not going to their OBGYNs to seek abortion services. They were going to the pain clinic. It was almost like an unspoken rule that even if you weren't part of the university, many of the other hospital towns have either a religious affiliation or it was just kind of known. So that place, served that even unbeknownst to many of the OBGYNs that their own patients were going, right? So, so now that's gone. And certainly, because of that, because people weren't even aware in many ways of who of your patients are going. It was, patients would be, or people would not disclose that information, because you understand in this environment, the environment hasn't changed. Like this was like this. We've been practicing with this degree of, resistance to it for really forever, probably. So now it is going to start showing up at people's doorsteps, and they're going to go to their OBGYN and seek information, guidance, and it's going to be, where they may not find, again, as it was with even, contraceptive care, you don't know what you're going to get in terms of the kind of support or education you're going to receive. So, yeah, access is a major problem. And we're going to know, this is the poorest state in the country. Are people going to be able to get in their cars, take time off of work, drive out of state, fly out of state? Right. Absolutely not. It was enough. It was a major deal for someone to even make it, both emotionally, socially, financially, every level. It was a major lift for someone to gain the courage, the resources, just to access that one site right now. And of course, there were protesters always outside. So they had to overcome a lot just to seek that care now. So now that it is, out of state, and, the states we're surrounded by are immediately not available either, you're really talking about plane tickets and things like that. And that's just not, these are many people who've never been out of the state in some instances. So it's just a non-option for many people now, even when the prior option that they had was also extremely limited.
I think, a lot of times when you hear this conversation, you think it's a singular issue, a singular procedure, a singular choice. That's a lot of the ways that the conversation is framed. And as people who are interested or support, I guess, comprehensive reproductive health and support having a full range of all your decisions. And I still see people, and I'll, even going through birth control options, and like, oh, well, nobody's ever mentioned that to me before. And you're like, well, I don't understand. Like, this is part of all your options. Doesn't mean you have to choose that option, but you should know what all your options are, because as our life changes, as we grow, and as our family grows, or our choice, our career grows, whatever, we make different decisions. But I think the other thing, kind of thinking about, access is huge, but also as clinicians, like the clinical implications, to your point, people are going to come to us and ask what to do, but also people are going to come to us when they've gone somewhere else and made a difficult decision by a non-reputable provider, and having to figure out what to do about that. But also the implications of things during pregnancy. So some of what they call them, the trigger bills, right? Ban access except in the case of life-threatening challenges to the pregnant person. Some, and not all, ban or allow access in the case of rape or incest. But there are many other issues while women may need to get terminations as well. One of the things I think of often is the lethal anomalies that happen during pregnancy, and thinking about those women who are going to be forced to carry to term, but there's plenty of others. But talk to us a little bit more about the clinical implications as a person who's going to take care of women who have to make difficult decisions, who might not have access to contraception, who might be 15 and have their first sexual experience and have no idea that's how you become pregnant. I mean, because that's a reality in some parts of our country.
Yeah, the clinical side of it is really probably one of the most egregious and upsetting, that all physicians, the whole medical profession should be really, up in arms about, regardless if you're an OBGYN, because now you have something that we trained for, so long, where there's so many nuances to medical care. And this is why you have professionals in this space that you have to train and get hands-on experience. And so even as we're thinking about, designing a clinical trial or designing intervention, we have to think about all the risks, all the benefits, all the ways it can impact health across the spectrum. And yet we have a law that now kind of puts out there within bullet points to say what you can and cannot do without any detail, which leaves us completely exposed, because not just to Are you doing the right thing medically, which is kind of where we were prior to that, but you are faced with potential criminal implications for the choice that you make as a provider. So when those two bullet points, life of the mother, because that's what it says, in cases of the life of the mother is at risk, and rape, and the rape has to be already with brought to charges, or rather the person has had to go to the authorities. So it's not like my patient comes to me, says, I was raped, do a pregnancy test, you are pregnant, and I can say, yes, I've confirmed through the story, which is, how we take care of our patients. We don't go say, where's our police report? We just take care of our patients. But now we have to be like, where's the police report? I've never had to look up a police report, or how do I confirm that? Or who do I call? And, when is that timeline of how that has to happen? None of that's spelled out. So what does that mean? That's just a no. Even if it's in the bill, it doesn't matter, because this is not where, again, if this wasn't happening already in many hospitals and practices, I don't see it happening now, where suddenly that gets, the door gets open to that. As it relates to life of the mother, our interpretation is very different, right? Like, our interpretation is, you have a medical condition that will put you at risk significantly enough that you could die, right? Like, we could think of a long list of those too. You've had heart failure in your prior pregnancy. You have a clotting disorder where, being pregnant elevates your risk of a blood clot and you could die. Pulmonary hypertension, you had a near-death experience in your last pregnancy. You have severe depression where you're already suicidal, and this pregnancy is leading you to be that even further. So we have a long list of conditions. Those are where the person's not knocking on death's door, where they're acutely unstable. Left up to interpretation, one may suggest that that is what was intended in the bill, that you are about to die, and that is when it is appropriate to intervene. So they talk about this chilling effect on OBGYNs in practice, that you are going to hesitate about offering, discussing, and even intervening, when otherwise it would be very clear to you that this would be the right thing to do. So that is where you're going to have, there's no clarity there. There's no obvious, direction on who makes that decision, how quickly they're going to make that decision. Has that decision been made today? Could someone come into one hospital today in that situation, where providers are likely going to do what they consider best and document it and just hope. But again, this isn't up against malpractice or a lawsuit, or up against, a medical review where we decide you didn't do the right thing medically. This is up against jail time, so that is, just the fact that that has now been taken out of our hands of determining what's the best thing to do medically for these very cut and dry situations, these situations that are clearly medical, not to say that those are the only ones that are justified for a person to choose an abortion, but that is what we're left with now, or even in the ones where it is something very medical, that's out of our hands, there's no clarity there, but the law is already there. So you may then be put through the process, which no one wants to go through. So a lot of, profound impacts there, where people, and medical providers are really left in this vulnerable situation that's going to cost lives. It's going to cause trauma. There's no way around that, because we know certain conditions, like you may be fine at 8 weeks pregnant. It's when you get to 24, 28. It's later in the pregnancy that we know those problems come up. It's not, you are stable at 8 weeks. If you have a clotting disorder or you have heart failure, you tend to do okay early in the first trimester, when abortion would be safe and simple procedure. Not so when you're 24, beyond the second and third trimester, that is when the complications start. So that is when, and it happens very commonly here, actually, in Mississippi, where someone may not choose that, but then they're asking for it once they get to 30 weeks and they can't breathe, and they're thinking about the children they have, and they think like death is really facing them, and now it's too late. So this is going to become a frequent problem. And we in Mississippi have always been thinking this. We've been living under these conditions for longer. There are states out there that have now been jolted into this, who had more expansive access just a few weeks ago. and now are jolted into this environment. So yeah, it's going to be something we are going to be facing and struggling with, hopefully, until things change.
Hopefully. I won't perseverate on this too long, but thinking about trying to take comprehensive care patients and you might have to go to jail with a felony charge and get fined is just blows my mind.
Yeah.
But anyway, like I said, I won't perseverate on that.
Yeah.
But another kind of thing in the clinical realm and thinking about the nuances of pregnancy. So we know that, half pregnancies in this country are unplanned. We know that access to contraception is iffy at best. We know that a lot of women have irregular pregnancies or irregular periods, right? So they don't even know that they're pregnant. And so, some of the laws are also fixed on like the 6-week rule, or they have these hard stops on the weeks. In reality, a lot of women don't even know that they're pregnant at that point. So talk a little bit about just kind of those nuances of just periods and early pregnancy and unplanned pregnancy and how people are going to have to negotiate those type of things.
Yeah, I mean, the conversation I've been having with my patients lately has had to change, whereby, I'm someone who certainly believes in reproductive justice, patient-centered, counseling, where someone tells me, I don't want any birth control, I'll counsel, I'm not putting pressure on them, but I am having to spell out for them what to expect if they're off birth control and they have an unplanned pregnancy. So the person tells me they do not want to be pregnant, but they also tell me they don't, they're, having intercourse, but they don't want to use birth control. Fine. I prepare them, right. I prepare them in what to expect, what their options are, right? What their options are. I fear, and I'm very concerned about emergency contraception, because we already know people are out there completely uninformed about how medications like Plan B or Ella work. They don't understand that it's a high dose of progesterone, which is the pregnancy hormone, which if you're already pregnant is not going to terminate a pregnancy. It's a drop in the progesterone bucket. So you are pregnant already, more progesterone. It's not going to harm that. However, we know medicine and science did not matter in the production of the laws we're dealing with. So same situation for that. So I am very concerned. The cost of that over the counter is about 40 to 30 to $50. And that is not something a lot of people have on hand in that moment. They may not know the timing around using emergency contraception. Now it feels like something that needs to be in every shelf, right? Like now, because who knows what's going to happen to it in terms of its access. So it almost feels like the way we have Pepto-Bismol or some kind, no product endorsement here, just the way we have like any kind of medication just in case. I have to talk about that a lot more in terms of preparation, because we just don't know, because the timing becomes very important. The next level is copper IUDs for the use of emergency contraception. That's exceedingly limited, because we know that can work to prevent implantation, where you're talking about early cell division taking place and doesn't, now it can stop, potentially sperm reaching an egg and stopping fertilization, but can also stop, fertilization from implantation from happening. So that's probably going to be in the crosshairs very soon. And many people don't support that even now or make it accessible. So the education, it has to get much more intensified for people to prepare and then have the tools to take care of themselves. So that's to say, absolutely, I believe in over-the-counter birth control. That's something we need to be pushing for. I know there's work around that within the FDA, should be happening already, that a progesterone-only mini pill, is a medication that is safe for most people. There's a small number of medical conditions that can't, use that from the outset. And it is small, it's probably smaller than the people who shouldn't be using aspirin, for example. Right. But we have aspirin on the shelf. We sell alcohol over the counter, and that kills lots of people. So it's to say progesterone only pills should absolutely be over the counter. People need to know and make access to emergency contraception themselves. But yeah, there's going to be a lot around, just preemptive education. I have to tell people now, you may not ever have been thinking about this, because people don't go walking through life like, oh, I can't wait to have an unplanned pregnancy and then have an abortion. Like, exactly. When's my chance? Like, nobody's walking around doing that. So people are often not thinking about it. I have to tell my patients now, okay, well, you have to know that this law has changed, and this is what you're going to face if you face this situation, that you, your friends, your boyfriend, your partner, your girlfriend, everybody needs to know this, because when the conversation comes up. So this is one of those scenarios where, sadly, our education system doesn't take this on. Only some segments of our health system are taking it on, meaning some providers are not still counseling people about this full spectrum. But yeah, we're our best option right now is prevention. And sadly, we knew, like, within days, that was already the same day, people were already talking about limiting contraceptive access. So it's something that goes hand in hand. One would imagine if those who are trying to prevent abortion would also love birth control, but it isn't the case. So we have to work on both of those fronts. And as those who are still fighting to protect access to full spectrum reproductive care, including abortion, we can't take for granted access to preventive measures. And then to the other point with that, there's so many medical conditions that we use what we call birth control for, and even medications that we use for abortions potentially, like methotrexate, is being banned and limited and not prescribed. And that's used for people with certain medical conditions use that, but it can be used for pregnancy termination, particularly with ectopics, which we never even thought about as abortions before. It's kind of its own category. Right. I was like, I've never called an ectopic an abortion in any of my training. It's just an ectopic. And it's an ectopic, and the treatment is ectopic treatment. It was never kind of put in the same boat. But we have to think about everything we took for granted as just medical care. You have heavy periods, you have PCOS, you have amenorrhea, you're infertile and you're trying to get pregnant, and you need to use birth control pills in the months leading up to your fertility cycles. You have precancerous changes in your uterus, and you want to be on high dose progestins in order to limit that progression, IUDs to limit that progression. All of that could be up for grabs. And so even people who've been vehemently fighting access to abortion will find themselves with a medical condition that birth control or some contraceptive method is a treatment for, and they themselves won't have access to it either. So this is, going to just comprehensively impact health of women and people with reproductive capacity and uteruses, across the lifespan. So that's really, consequences that were not considered by folks who wrote the law.
Yeah, it's very nuanced. It's very far-reaching. It's very overlapping. And thinking about, I thought about a few things, but thinking about contraception and how we use it for non-contraception reasons, and thinking about people who currently practice in religious facing hospitals, right? So that's always been an issue. And having this when I was in Kenya, it was a Catholic hospital. So if they needed to be treated with combination birth control, we had to send them somewhere else, right? And so that's frustrating when you have a treatment that works, but you have to send them to another place to get it, and they might not be, and to our point about access and transportation, and just having time in the day with competing priorities, whether or not they'll make it there to get that or not. So that can be challenging. I know we're running out of time, and there's so many things to talk about. But before we jump off, I wanted to kind of just briefly touch on a couple things. Speaking kind of specifically to the marginalized populations in this country, and you touched on infant mortality, and those numbers are similar when we think about maternal mortality, specifically with Black women in this country. Just briefly tell us about, I guess, what your biggest fear is for those populations as we move forward.
Certainly. I mean, I think we know because of the very foundations of this country and its care for Black women, brown women, that racism defined how Black women's bodies were treated or considered. The reproductive capacities of Black women have always been used for other purposes than their own, throughout history, both in abortion, pregnancy, contraception. Black women's bodies have been used and mistreated, and racism has structured so much of that. And that plays into even now and why we're seeing these elevated rates of maternal death. And even in this policy, when we're thinking about reproductive justice and how that is really supporting across the spectrum. When you want to have a baby, we want you to have the baby be healthy, that baby to grow and thrive and survive, not just survive, but thrive. You live in conditions that allow you to have the family that you want to. You have the freedom and safety to do that. That is like truly looking at with love, compassion, and respect and dignity over a person's life course. And this is just yet another place where that is not happening. And we see the policies that structure the experience of Black and brown people, where they are vilified, they're policed. Who is likely to go to jail for this? It is not going to be your white college, university student, daughter of a powerful person who found herself in a bad situation. She's not getting taken away in handcuffs. The policing is going to happen to Black and brown people. The jail times are going to happen. The convictions are going to happen. And so if they're pursued, like who gets chosen to do that versus who gets the pass? Who gets the phone calls made on their behalf to handle things quietly and with discretion. Those, graces will not be extended to Black and brown people. And then, of course, access to the full spectrum services. We've noticed that where voter rights suppression is happening is where abortion rights are equally, oppressed. So people have just no voice in terms of what happens with their life. And so this is going, this is going to exacerbate what we've already seen on so many fronts around not now just health implications, but the major social, financial, political implications to it. Because it's obviously setting off a cascade of things. It's not just this one thing around abortion. It is around your reproductive freedoms. And so yeah, it is undeniably a major threat to something that was not even we were still under a situation of a really dire situation around, particularly Black maternal mortality. And because this isn't done enough, there's no way to do this type of policy change with, taking someone's full dignity, health and life. There's no way to restrict this to that extent in that kind of way, but in particular now, and it won't be on the news. There'll be lives kind of devastated without being able to measure it right away. It's going to take, in some places, time. There'll be these catastrophic stories that come and go that may or may not make the news, but it is something that those of us who care about this, have to do the measurement, have to keep the eyes on, have to not let people miss what is happening to our communities, or tell the stories or redefine. We have to, call it for what it is, and be sure that as we see the fallout from it, we are highlighting the needs of marginalized people.
I think just to underscore something you said a few minutes ago, most people we'll say most people, if not all, don't wake up today and say, oh, I think I want to have an abortion, right? Most people don't even think about it truthfully until they're in the situation when they're faced with unplanned pregnancy for whatever reason, or a challenging pregnancy for a health condition. And then you have to make that decision in the moment. And so I just want to make sure that those of you who are listening, our conversation is about having full access to health choices so that you can be your full person, health-wise and just in general. And a lot of women have to make these choices, not because, we often think about the young teenager who just didn't know, but we also think about women who may be in their 40s, right? And have 3 kids that are already in college even, and are facing with an unplanned pregnancy and are making a different decision for a different set of reasons. And so the choices run the gamut, but what we believe is that everyone should have the ability to make the choice that is going to allow them to live their best life, period, point blank. So kind of in closing, this is a heavy topic, but I do think there is some room for optimism here. And I try to end on an optimistic note. I appreciate you having the conversation and being very upfront, honest, and vulnerable with this conversation. And I think we will continue in larger groups to have the conversation as the issues go on. But tell us something, leave us with an optimistic word of wisdom, what you're looking forward to, or what you want to charge people to do to continue this conversation and maybe turn the decision back the other way.
Yeah, I mean, I think for me, something that's been resonating is that there are really no more fences to sit on anymore over the last few years. If it relates to racism, like George Floyd, everything that happened with that took that fence away. When we look at like just COVID, what we're looking at health inequities, when we're looking at takes that fence away over like what it means to have access to healthcare, what it means to be safe. Now this has happened, and it really just kind of shines a light to say there's no more fences to sit on. This will affect our lives. This will affect the lives of people you care and know about. There is no person. It's not a women's issue. It's not just a people with uterus issue. It's obviously just a life in a human issue. And if you're like out there and saying, well, I'm focused on orthopedics and I'm a man, well, you may find yourself with an unplanned pregnancy. If you say I'm, if you're a trans person, if you're doesn't matter where you're from or who you are, this will affect your life at some point, or even the precedent to be able to control what you do with your health will affect your life. So this is a place where it's to say, it's almost a relief to be like, okay, we have to do something. It's not appropriate to sit back now. And hopefully we can now be very explicit about what reproductive justice is and how that is the policy that should define how health is structured, not just an idea of women's rights and feminism and these things that were once exclusive to others. I think in the formation of reproductive justice, it was always something that created a space for all people to achieve their best lives. And so now we can say, if we're going to design something moving forward, Roe in and of itself was not protecting Black and Brown people from the loss of their reproductive freedoms completely. It wasn't doing that, 6 months ago. So, sorry, I have a crying child. But it wasn't doing that, right? It wasn't fully achieving that. So now we have an opportunity to create and design a system really founded on a principle designed by Black women who understand all the intersections of oppression that can come at you, if it's, from your color, your poverty level, your education. That was in mind when the design of reproductive justice was created. So that's what we should go to as when we create something new, when we look for new laws, not this kind of, myopic or very focused way of saying you can have an abortion. Like, no, you can actually have reproductive justice. You can, have sex, give birth, be pregnant, have contraception in a way that, uplifts your dignity. That should be the standard. It should not just be go in the shadows of the night shamefully and get an abortion only to be left with no support, or be pregnant and have a baby only to be left with no support. Maybe now we have an opportunity to push for something better that is accessible to everybody. So maybe we take this as a chance to do something even more broad and powerful than even what we had with access with Roe.
I agree. I think that is a perfect close and an excellent charge, and leaves us with some optimism and some work to do. So thank you again for being with us today.
Thank you. It's
Thank you
great.
for sharing. Thank you for all the work that you do every day. We appreciate it. Mississippi appreciates you.
Yeah.
And take care. We'll talk to you later.
Talk soon. Thanks so much. Bye.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.